Cardiac arrest is the moment when blood flow to the body stops, depriving vital organs of oxygen. However, the brain, remarkably resilient, does not die instantly. Its gradual death begins with acute hypoxia, oxygen starvation, which triggers a cascade of destructive biochemical changes in cells. This is precisely why doctors have a chance of saving the patient if they intervene in time. A key factor in brain damage is the sharp decline in the production of the adenosine triphosphate, the main source of energy for cellular processes. Without this substance, the exchange of molecules across cell membranes is disrupted, leading to disruption and damage to their structure. The loss of potassium and the excessive accumulation of sodium and calcium inside the cell trigger mitochondrial destabilization, causing cells to lose their ability to function normally and switch to self-destructive processes. At the same time, electrochemical processes in neurons are disrupted, leading to the release of excess neurotransmitters. Some of these cause intracellular disturbances and stimulate the production of inflammatory mediators. These substances, in turn, lead to vascular obstruction and rupture, raising the risk of cerebral edema. Edema is dangerous because it causes an increase in the volume of nerve tissue, which significantly increases intracranial pressure, damaging brain structures and impairing their function. Brain herniation, the displacement of its parts relative to each other, is one of the most dangerous consequences of edema. This condition can cause irreversible disruption of neural function and significantly complicates functional recovery, even if the patient is saved. First aid physicians in cardiac arrest attempt to halt this process by using cold therapy and induced coma. Cooling the head slows metabolism, reducing the oxygen demand of neurons, while medically induced coma helps reduce brain activity. The first minutes after cardiac arrest are extremely critical. Consciousness is lost within 10 to 20 seconds, and shallow, labored breathing begins. The pulse gradually slows and disappears, and cells begin to suffer from oxygen deprivation. Seizures can occur 15 to 30 seconds later due to a disrupted neurotransmitter balance, placing the brain's neural networks under significant stress. If resuscitation measures are not initiated during this period, cells begin to die at an accelerated rate. Within 2 to 5 minutes after cardiac arrest, clinical death occurs, a state in which signs of life are absent, but there is still hope for full recovery. Blood circulation ceases completely, muscles lose tone, there is no response to external stimuli, and the eyes are wide open and unresponsive to light. Intensive cell death begins in the brain, primarily affecting the areas responsible for higher functions of consciousness and thought. It is from this moment that irreversible processes begin if supportive methods are not applied. If resuscitation is not initiated, or is initiated too late, after 5 or more minutes without blood flow, the brain undergoes irreversible damage. Decortication, the death of the cerebral cortex, occurs, leading to permanent loss of consciousness. In this state, respiratory and circulatory support can be provided with equipment, but the chances of returning to active life are virtually non-existent. Exceptions include cases of extreme hypothermia, when metabolic processes slow down, allowing tissue preservation for hours. Body temperature plays a decisive role in the survival of the brain after cardiac arrest. In extremely cold conditions, brain tissue maintains its functions significantly longer, slowing metabolism and reducing oxygen requirements. This is precisely why successful resuscitation after prolonged clinical death in low temperatures has been reported worldwide. Cold acts as a kind of shield, providing additional time for rescue. Every second is crucial for doctors, as the effectiveness of resuscitation efforts declines critically over time. According to current medical standards, attempts to revive a patient last at least 30 minutes, the key requirement being the absence of signs of biological death. One such sign is Beloglazov syndrome, a unique pathological reflex in which the pupil becomes vertical when pressure is applied to the eyeball, precluding the possibility of successful resuscitation. The state of the brain after cardiac arrest directly impacts treatment outcomes. Stories of patients like Audrey Mesh, who survived prolonged clinical death with low body temperature, inspire scientists to explore new ways to improve resuscitation. Doctors use head cooling, induction of induced coma, and modern circulatory support technologies to slow or prevent swelling and neuronal damage. Thus, knowledge of the physiological changes in the brain during cardiac arrest allows us to understand how and why the brain does not die immediately, opening up possibilities for resuscitation. In the next section, we will discuss in detail the time frame of human brain survival and the factors influencing the success of resuscitation in order to understand the feasibility of restoring consciousness after clinical death. Timeframes and features of successful resuscitation. In the time following cardiac arrest, dynamic and irreversible processes occur that impact the chances of successful resuscitation. The first few seconds are critical. Consciousness fades within 10 to 20 seconds, and breathing becomes shallow and hoarse. The body's nervous tissue experiences a severe oxygen deficiency, triggering a series of biochemical disturbances that affect cellular viability, especially in the brain. Doctors call this period the golden age, when the potential for intervention is greatest. Between 2 and 5 minutes after blood circulation ceases, clinical death occurs, a state in which vital signs are temporarily lost. However, there is still a chance to restore the patient to consciousness if resuscitation measures are administered promptly and effectively. Pupils are dilated, muscle tone is absent, the skin takes on a pale, bluish tint, and the most vulnerable areas of the brain begin to necrose. It is during these minutes that the critical line between life and death remains. Without adequate medical care, irreversible changes begin to affect brain and body tissue after more than 5 minutes. Necrosis of the cerebral cortex becomes irreversible. Even if life support systems maintain blood flow and breathing, consciousness is no longer able to recover. This period is often accompanied by severe neurological complications and the loss of fundamental life functions. However, research shows that maintaining extremely low body temperature, as in hypothermia, significantly slows down the process of cell death. Temperature plays a key role in resuscitation prognosis. Cooling is known to help slow brain metabolism, preventing the development of edema and destructive biochemical reactions. In practice, doctors use head cooling, induce induced coma, and employ pharmacological methods to slow metabolic processes. These measures significantly extend the resuscitation window, as evidenced by rare but remarkable cases of resuscitation after an unusually long time following cardiac arrest. The duration of successful resuscitation is the subject of serious ethical and medical debate. Current protocols recommend attempting to revive the victim for at least 30 minutes, provided there are no signs of biological death. The ultimate criterion is the so-called Beloglazov syndrome, in which the cessation of brain activity becomes obvious and indicates the impossibility of recovery. It is important to understand that active efforts are stopped only when convincing signs of irreversible death are confirmed. Cases of patients returning to life after prolonged periods of clinical death generate intense interest in the medical community and the general public. For example, the story of British woman Audrey Mash, who spent 6 hours in a state of hypothermia with preserved brain function, has become a symbol of the incredible capabilities of modern science. Her resuscitation, with virtually no serious neurological sequelae, inspires specialists to further study the mechanisms that protect nervous tissue. The story of Anton Dimov from St. Petersburg demonstrates the complexity and drama of the fight for life. Multiple cardiac arrest and induced coma did not prevent him from returning to a full life. This example highlights the need for a comprehensive and multimodal approach in resuscitation, where every hour and every minute is crucial. A medical procedure involving hypothermia, performed on American singer Pam Reynolds, sheds light on the brain's protective mechanisms during elective cessation of blood circulation. Not only are the technical details of the procedure fascinating, but also the patient's accounts of her subjective, out-of-body experiences. These accounts raise numerous questions and stimulate discussions in the fields of neuroscience and the philosophy of consciousness. Astonishing cases of Lazarus syndrome, in which patients declared dead suddenly revive, continue to baffle specialists. The stories of Wilma Thomas and Anthony Yale demonstrate that spontaneous resuscitation is possible, even after prolonged absence of electrochemical brain activity. Nevertheless, they highlight the limits of our scientific expertise and open the door to new research into the mechanisms of consciousness restoration. The scientific explanation for near-death experiences links them to the brain's response to oxygen deficiency and biochemical changes. Modern research reveals similarities between these experiences and the effects of psychotropic drugs, suggesting they are complex hallucinations caused by a combination of various physiological factors. This helps differentiate subjective sensations from objective biological processes. Today, medicine employs cutting-edge methods to prolong brain life after cardiac arrest. Among them, induced coma, pharmacological support, active cooling, and machine-assisted blood purification are key. These technologies offer a chance to preserve cell viability and prevent destructive processes. However, the effectiveness of each procedure depends on the timing of initiation and the individual patient's characteristics. Perception rapidly fades after cardiac arrest as oxygen levels in the brain drop. Consciousness briefly functions for the first few seconds, after which a complete loss of sensation occurs. This has been confirmed by modern neurophysiological research and explains why subjective experience ceases, and these experiences form the basis of near-death visions and hallucinations. Preserving the brain during cardiac arrest is a key focus of modern medicine. Despite advances, most victims do not return to full functioning and experience various neurological impairments. This has stimulated the search for new, innovative methods for restoring consciousness, among which electrical stimulation is considered promising. The medical community continues to monitor technological advances and study the factors that influence the success of resuscitation. Moving on to the next stage, it is important to delve into the psychological and social aspects of the clinical conditions experienced, as well as to consider the possibilities of long-term rehabilitation and support for patients after their return to life. Brain death diagnosis, unusual cases and scientific perspectives. Diagnosing brain death is a complex and critically important task, performed by doctors in situations where the patient is being kept alive by life support systems, but there is complete necrosis of the cerebral cortex and upper spinal cord. In Russia, this diagnosis requires a combination of symptoms: loss of consciousness and muscle tone, complete lack of response to pain, motionless eyes with dilated pupils that do not react to light. The corneal reflex, oculocephalic reflex, and oculovestibular reflex should also be absent, and irritation of the back of the throat should not cause contractions. Furthermore, the patient is unable to breathe independently. Diagnosing brain death is complicated by a variety of factors. For example, in patients in shock immediately after resuscitation or in profound hypothermia, some signs may be unclear. Therefore, doctors use a variety of methods to confirm the diagnosis, ranging from clinical tests to complex imaging studies, such as cerebral angiography or electroencephalography. Accurate diagnosis plays a key role in decisions regarding the withdrawal of life support and potential organ donation. From a legal and ethical perspective, brain death is considered the final death of a person, although their heart and other organs may temporarily function thanks to medical assistance. Russian law recognizes this diagnosis as official death, allowing for transplant surgeries. Religious traditions, including the Catholic Church and Islam, also recognize brain death as the end of life. Medical practice today is actively developing ethical standards to ensure respect for patient dignity and transparency in decision-making at critical moments. Cases of resuscitation after prolonged cardiac arrest and even declared brain death sometimes seem miraculous. British tourist Audrey Mash, who found herself in the Pyrenees with a body temperature of just 28 degrees Celsius, found herself in critical condition. Despite the dangerous cold, which virtually halted bodily processes, immediate medical attention preserved the viability of her nerve tissue. After several hours in intensive care, Audrey woke up with almost no serious injuries, only minor difficulties with fine motor skills, which was a true medical triumph and an example of a rescue from near dead end. In St. Petersburg, Anton Dimov's story became famous thanks to the professionalism of his doctors and the patient's extraordinary strength. After a pulmonary artery occlusion, his heart stopped 15 times, but thanks to an induced coma and constant monitoring, his life was saved. Although such cases are rare, they demonstrate the capabilities of modern medicine and force a reconsideration of the boundaries between death and life, opening the way for future research into recovery from clinical death. American singer Pam Reynolds' surgery caused a sensation thanks to its use of hypothermic cardiac arrest. To increase the chances of recovery, doctors lower the patient's body temperature and cut off oxygen supply, thereby minimizing brain damage. During the procedure, Pam experienced unique experiences, which she interpreted as out-of-body experiences and visions of deceased loved ones. The scientific community is inclined to believe that this could be the result of activation of certain areas of the brain, but for many, these stories remain evidence of the existence of something that goes beyond the usual understanding of consciousness. Wilma Thomas from the United States became the heroine of another astonishing case. After 17 hours of no brain activity, the woman was disconnected from life support. But 10 minutes later, she suddenly moved her arm and opened her eyes. This phenomenon challenges the definitive definition of brain death and inspires doctors to develop new methods for monitoring and treating patients with minimal brain activity. Similar episodes occurred with Anthony Yale of Ohio, who was pronounced dead after a heart attack, but suddenly revived 45 minutes later without cardiac activity. This phenomenon, known as Lazarus syndrome, raises many questions. While some patients make a full recovery, others experience only a temporary return to life with severe consequences. Science still cannot provide a comprehensive explanation, but such cases stimulate the search for new biological and neurophysiological mechanisms associated with the restoration of vital functions. Near-death experiences, experienced by some people attempting to explain these phenomena, are believed by scientists to be the result of complex biochemical processes in the brain. Suffocation, increased carbon dioxide levels in the blood, the release of endorphins, and the effects of active substances such as ketamine all play a role. In this case, the visions are not actual out-of-body experiences of the soul, but vivid hallucinations caused by damage to certain areas of the brain, particularly the temporal lobe and limbic system. Prolonging brain viability after cardiac arrest is only possible at extremely low temperatures. This is why modern resuscitation protocols utilize induced coma, head cooling, machine-assisted blood purification, and high-pressure oxygenation. These methods reduce metabolism and prevent swelling, improving the chances of successful recovery. Technological advances in brain electrical stimulation and cell therapy are opening new horizons in restoring neural function. The ability to perceive anything after cardiac arrest persists for only 10 to 20 seconds, after which consciousness is completely lost. During an induced coma, the patient is completely unaware of or aware of their surroundings. This is confirmed by numerous clinical studies, despite isolated cases of patients reporting out-of-body experiences. Science explains these episodes through neurophysiological phenomena, and active work is currently underway to unravel the mysteries of consciousness and its boundaries. Preserving the brain during cardiac arrest is synonymous with preserving life, highlighting the need for immediate and professional assistance. Unfortunately, successful resuscitation is rare and still depends on many factors. Among those fortunate enough to survive, neurological complications are common: memory loss, paralysis, impaired motor function, speech problems, and emotional reactions. This challenge stimulates the development of medicine, where the main directions are new technologies and methods for more complete recovery of victims. Thus, science stands on the threshold of revolutionary changes in the understanding and treatment of brain death and the restoration of consciousness. Modern methods and discoveries in bioethics, transplantation, and neurology are opening up prospects that until recently seemed impossible. This gives hope to millions of patients and their families, and the experience of such unpredictable stories inspires medical professionals around the world. We continue to explore the mysteries of the human brain and its incredible resilience, preparing for new discoveries in the next chapter of our story.